Hi, good afternoon. Thank you. Good afternoon. We're going to go ahead and get started. My name's Lori Martin, and I'm here to introduce Dr. Peter McGuire. And before that, I just wanted to remind everybody to review your session evaluation, which is provided. A link was provided when you first were registered. And so please remember to complete your evaluation form so that Dr. McGuire gets the glowing review he deserves. And then as a courtesy to everyone else in the session, please remember to turn your phones off or silence them. Dr. Peter McGuire is the head of Metabolism, Infection, and Immunity section and an investigator in the Medical Genomics and Metabolic Genetics branch of the National Human Genome Research Institute at the National Institutes of Health. He received his bachelor degree from Villanova University, his master's from New York Medical College, and an MBBCH with honors and an equivalent to a doctor from the Royal College of Surgeons in Ireland. After completing a combined residency in pediatrics and medical genetics at Mount Sinai Medical Center, he was awarded a fellowship in biochemical genetics from the American College of Medical Genetics and Genzyme. Upon completion of his training, he remained at Mount Sinai as a junior faculty member in the program for inherited metabolic diseases before joining the NIH in 2016. Dr. McGuire is a board certified in pediatrics, clinical genetics, and biochemical genetics. Throughout his career, Dr. McGuire has been focused on improving the care of patients with disorders of mitochondrial metabolism. By combining his training in immunology and biochemical genetics, he has fashioned a translational research program to understand the interplay between mitochondrial metabolism and the immune system. His NIH Clinical Center protocol is the first organized effort to study immune function in patients with disorders of mitochondrial metabolism. This study aims to demonstrate that these patients can be informative regarding the role of mitochondria in immune cell function. And if you haven't had a chance to stop by his table and learn more about his NIH program, I highly encourage you to do so. And without further ado, Dr. McGuire.
Thank you so much, Lori. I really appreciate that very kind introduction. I will have to maybe periodically look around the column here to make sure I can, see if there are any questions or anything. First of all, I just want to take the opportunity to thank the organizers for giving me a chance to come and talk to you. It's been about 3 years, I think, or so since I talked to the group last about some of our studies. And so my group studies essentially were very concerned about infection in patients with mitochondrial disease and how it can cause kind of a deterioration sometimes in the patients in terms of their function. So we look at things like the immune system and how, is the immune system equipped to be able to protect patients against things like infection. So I see a lot of you nodding your heads that you've experienced this before as caregivers or even as individuals yourselves who are affected by mitochondrial disease. So I'm going to talk today a little bit about some of the clinical data that we have found in seeing all of our different patients with different mitochondrial diseases at the clinical center, as well as some studies we do in animal models of mitochondrial disease, because as you can imagine, we cannot give infections to human beings, but you can give it to things like mice and mice with mitochondrial disease, which can be very informative in terms of how individuals with mitochondrial disease handle infection. So this is just a quick outline of what I'm going to talk about. So the first section is basically the consequences of infection in mitochondrial disease. And these consequences are, a lot of them occur in individuals who are not affected by mitochondrial disease. It's just that individuals who are affected by mitochondrial disease may not have the capacity to make the adjustments or the changes that are actually required by infection. Okay, so I'm sure a lot of you are familiar with infection and mitochondrial disease. And infection, can be pretty detrimental in patients. Sepsis and pneumonia are the two most common causes of death in children with mitochondrial disease. And this was a study that was published as of 2 years ago, looking at a fairly large pediatric cohort. Sepsis is also one of the top 5 admitting diagnoses in pediatric patients with mitochondrial disease. This was a nice study that was done by a group at CHOP. Up to 80% of children with mitochondrial disease can experience infections, recurrent infections actually, so over and over again. And a lot of these infections are actually respiratory infections, so things like sore throats, runny noses, earaches, things like that. And it turns out that infection is actually the leading cause. This is a paper that was published many years ago, actually, by Bob Navio, actually, so for those of you who know him. And they found that basically infection is one of the leading causes of neurodegeneration in individuals who are affected by mitochondrial disease. So one of the things that I'm concerned about as a clinician is this scenario here, which is essentially metabolic decompensation. So this is essentially when individuals with mitochondrial disease, they have an infection, this can become a life-threatening event, right? So for very simple coughs, colds, fevers, things like that, patients can actually wind up in the intensive care unit. And as far as what's going on in terms of their mitochondrial disease, there could be things like a bioenergetic failure. Their lactates can spike and go through the roof, sometimes which can be very difficult to control. Their disease can actually progress, right? So symptoms that or level of functioning that they had before, they can lose milestones, and it can remain that way. In other words, that they don't actually recover those milestones. You could have organ failure, things like liver failure. Patients can become encephalopathic, meaning that their brain doesn't not to function very well during infection. They can have problems with their central nervous system. They can develop things called metabolic strokes. Has everyone heard of metabolic strokes? Yeah, so you say this to other people, and meaning people outside of mitochondrial medicine, they don't quite understand what it means, because for them, a stroke has to do with bleeding, right, or interrupting blood supply to a certain area of the brain. Whereas in mitochondrial disease, it's very different. It's because there's a bioenergetic problem. In other words, an inability to generate enough energy because of the stress of infection, and you get death of essentially nerve cells in certain areas of the brain. So a lot of these patients, mostly what I'm talking about are kids. I'm not saying this doesn't apply to adults, but I'm basing it on a lot of what we see in children. They require extensive care in the intensive care unit. You can see here in the picture, there's all this machinery around my little picture here. This is actually not a patient, just so you know. This is something I grabbed off of Google. But it does kind of demonstrate, the level of care that these patients actually require. There's a little tiny baby head in the middle of there, if you look very closely. And that baby is surrounded by things like IVs. They're being monitored, essentially, for heart rate and respiration. That machine over in the corner behind in front of the balloon is essentially dialysis. So there's a really high level of care that's required. And unfortunately, at this point, the treatment for many of these episodes are symptomatic, right? Meaning that we don't have a magic mitochondrial bullet that's going to fix this situation. So my group is kind of looking at, kind of what can we do in this situation to help improve care of these patients, and also so we don't actually wind up in this place to begin with. Okay, so point number 1. The reason infection is bad for patients with mitochondrial disease is because it increases your energy requirements, right? So one of the problems, obviously, with mitochondrial disease is because of deficiencies in what's called oxidative phosphorylation, right? Your ability to produce energy, that can be severely compromised. And infection increases your basal metabolic rate. In other words, how much energy you actually need. So I'm sure, who in the room has been sick before? Whether you have mitochondrial disease or not, okay? What happens to your weight? Goes down, right? It goes down for a number of reasons, one of which is it's hard to keep taking in, calories and stuff because you feel miserable. Part of the other reason is because your basal metabolic rate increases significantly as a result of infection. And there's actually a calculation you can do. So in the Celsius, if you look at temperature in the Celsius instead of Fahrenheit like we're normally used to, for every 1 degree increase in temperature, your basal metabolic rate goes up 10% or more. Right? So 37.5 is considered normal. Let's go up to like 39 or 40, right? You're talking about, almost a 30, maybe sometimes even 40% increase in what your basal metabolic rate is or what your requirements are. So you have to take in a lot more calories. You feel miserable, and you can't do that, right? So you can't meet the requirements. So therefore, tissues that are affected by mitochondrial disease can fail as a result. Okay, one of the second reasons that infection is bad for patients. Has anyone in the room either cared for someone or personally had an elevated lactate? How about an elevated lactate during infection? Yeah. So one of the reasons is that because your mitochondria cannot generate energy so well, is you'll burn a lot of sugar. Because who's heard of ATP, right? ATP is the energy currency that the cell generates, right, to make the cell work and do all the functions that the cell can do. Well, if you can't generate it by the mitochondria, then you're going to generate it by burning glucose. And if you burn a lot of glucose, what's the result? Lactate, right? So you make a lot of lactate. So this, at the bottom, is actually imaging that we do in an animal, okay? And this is a mouse that we actually inject with, it's kind of like a drug that simulates an infection. So the immune system becomes activated, these animals feel miserable, and what you can see on the left are animals that are not injected with anything, and then on the right, they are injected with this drug called poly-IC, which simulates a viral infection. And you can see the liver in the middle lights up red, right? What that's telling us is that lactate, a lot of lactate's being made, just as, and this is a mouse that doesn't have mitochondrial disease, so just even normally, by developing an infection, your organs are going to switch over to burning a lot of glucose, and it's going to make a lot of lactate. Now, patients with mitochondrial disease are already prone to do this, right? So they're going to do it even more, and that's one of the reasons that lactate levels rise in the blood when you become ill. Okay. Another reason that infections are bad for patients with mitochondrial disease is they can actually cause damage to the mitochondria themselves. So this is a cartoon, which I'm sure may look familiar to some. This is basically how the respiratory chain works and how mitochondria work and how they make ATP. I don't want to get down to the nitty-gritty of that. What's important is actually on the right. We can actually measure the enzyme activity of these individual complexes, right? So these are the complexes. I'm going to try and go on both sides here, let's see. Okay, so these are the complexes in green, right? And then ultimately, they help to make ATP. Now, you can measure each one individually and how well it works. So that's what we do on the right, okay? So we're measuring complex 1 and complex 3 activity when we give a mouse this kind of simulated infection. We inject them with poly-IC. And what you can see is the gray bar, and I'll go over this side too, the gray bar is fine for the normal wild-type animal, the animal that's not injected with anything. You inject them with this kind of viral stimulant, basically, or it looks like a viral infection. The activity of those mitochondrial enzymes go down, okay? So this is in the liver. So basically, not only is the liver developing a lot of lactate, right, but their mitochondria are actually turning down or turning, you can't say turning off, they never turn off, but they turn down. So if you have a level of impairment to begin with in your mitochondria, that those enzymes don't work very well, and now you get an infection on top of it, you're basically knocking down your ability even more for the mitochondria to work. Okay. Another thing about the mitochondria becoming damaged is they can release mitochondrial DNA when they're damaged during infection. Now, I'm sure many of you may remember, the mitochondria actually contains its own DNA, right, which helps it function. The problem is when you actually damage mitochondria, you release that mitochondrial DNA, and that mitochondrial DNA, all it does is, it does many things, but one of the bad things that it does is it gets the immune system even more charged up than it normally is. So does everyone know what inflammation is? Right? Inflammation is when the immune system becomes activated, you can have fever, the immune system spills out all these different mediators and things. So what this does, spilling out mitochondrial DNA, ramps that process up even more. So the levels of inflammation go even higher and patients can become even sicker. So this is as a result, essentially, of having an infection. You can spill out mitochondrial DNA. And you can see in this graph here, this is looking at serum mitochondrial DNA in a mouse that's actually infected with influenza. Yeah, so we give mice the flu, basically. And when they get the flu, they spill out this mitochondrial DNA into their serum, and that can cause even more inflammation in these animals. And this has been shown in humans as well to happen. Okay. Another reason that infection is bad, it turns out that tissues that are affected by mitochondrial disease are actually very sensitive to immune reactions, right? So when you get an infection, the immune system's there for a purpose, right? That purpose is to actually get rid of the infection. But as it turns out, the immune system can actually be damaging to tissues that are affected by mitochondrial disease. So here on the left, these are electron micrographs, right? So these are looking at liver cells during an infection in a mouse that actually has mitochondrial disease. So when the mouse is, these pictures may be hard to see, but basically when the mouse, when you don't have, it doesn't have any infection, which is on the left column here, the mouse is fine. The mitochondria look fine, the liver looks, you'll just have to take my word for it. Unless there are any pathologists in the room, you'll have to take my word for it. They look fine, okay? You give that mouse with liver mitochondrial disease an infection, and what you get on the right, down here on the bottom, is mitochondria that swell up absolutely gigantic, okay? They become dysfunctional, and you start accumulating fat in your liver. So you get something called steatosis. Have you ever heard of steatosis or fatty liver? Fatty liver, basically. Fatty liver occurs in many different conditions, alcoholism being one of them. But these patients with mitochondrial disease, when they get an infection, develop fatty liver. And that's actually seen on the right corner here. When you stain for that fat, it shows up, whoops, things jumping all over the place, sorry. Here we go. So it shows up in pink. So essentially, these mice with liver mitochondrial disease develop fatty liver during infection. Okay, one of the other, so why is this actually occurring? Why is the immune response, bad? And it turns out that the reason is because the way that the immune system, cells of the immune system communicate with each other is they send text messages. That's my millennial reference right there. They send text messages to each other, which are little chemicals that they pass between each other. The problem is, if you're doing that in the vicinity of a tissue that's affected by mitochondrial disease, those text messages are not well received by tissues that are affected by mitochondrial disease. So these little text messages are called cytokines. Tissues that are affected by mitochondrial disease don't like cytokines. If you take essentially liver cells and you dump one of these text messages on it called TNF-alpha, and you look to see how well the mitochondria function, you can see here that when you put nothing on them, they function okay, but when you put on this text message called TNF-alpha, a cytokine, their ability to perform respiration, mitochondrial respiration, goes down. So these text messages, which are supposed to be good, right? It's supposed to help you fight off infection. Once again, I reiterate, tissues affected by mitochondrial disease don't like them. That's why we want to try to keep you healthy, keep you from getting infected. Okay, so when you take this text message and you dump it on a bunch of liver cells, so this is a normal mouse, and this is a mouse that has mitochondrial disease in its liver, and you dump that text message on the liver cells from that mouse, all this red basically indicates fatty liver. So the fatty liver that we see during infection, when we give these mice influenza, is because of the immune system reacting to the virus, making these text messages to communicate with other immune cells, and bystanders, liver cells, get exposed to this, and they develop fatty liver and mitochondrial dysfunction. Okay, so since this is what can happen when you have an infection. So we also ask questions of, since infection is such a serious thing, or can be, for patients with mitochondrial disease, how well does the immune system actually function in these patients? In other words, how good are they at even preventing an infection from happening, kind of staving off infection? So I'm going to talk about the immune system, what it is, and why it's important. So the immune system is made up of all different types of tissues. So you have mucous membranes, which kind of keep things from crossing into the body. You have tonsils. Does anybody still have their tonsils in here? I do, right? Tonsils are an immune organ, actually. And they actually help with kind of upper respiratory tract infections like bacteria and viruses and stuff like that. We also have, lymph nodes. When you go to the doctor, right, sometimes they'll feel your lymph nodes. That's to see if you, have infection or anything like that. The skin also serves as a barrier to protect you against infection. The spleen's really important. That helps for things bacteria and viruses that are floating in the blood. It basically filters it and gets rid of it. And then the bone marrow. The bone marrow is where all of these cells of the immune system are born, essentially. Okay, so this is a picture of the bone marrow. And basically, in your blood, you have red cells and white cells. And the white cells are the ones that are important for basically, getting rid of infection. I don't want to get disgusting, but has anyone in here ever had an infection where you've had pus? Yeah. Well, pus are white cells, essentially. They're dead white cells that have gone into that area to try and kill bacteria and stuff like that, and they die in the process. So they have their origins in the bone marrow. So there are many different types, and we're going to talk a little bit about some of them, not all of them. But basically, just so you know, there's a wide variety of cells that are created out of the bone marrow to help you fight off infection. Okay, so immune cells circulate through their job is essentially to circulate through the body, right? And they're on patrol. So they're on patrol to make sure that there's no invaders coming in that potentially could cause illness in an organism. So they circulate all around the body, and as I mentioned, the white cells are essentially one of the main types that do this to help protect you. Now, why is it important? Because our bodies, even at this very moment, every single one of us in this room, our bodies are being assaulted by microorganisms and things from the outside, right? And the immune system functions essentially to protect us against things like bacteria or viruses or fungi or parasites. If you're traveling internationally, parasites can be a real problem. But things that we don't tend to think about are things like cancer, things like pollutants, other things that can potentially harm us. The immune system is also involved in basically patrolling and making sure that those things don't get a foothold in the body. Okay, so how does the immune system learn to protect us? Well, it basically learns in two ways. It either learns by you get the infection yourself, right? And the immune system reacts to it and then learns how to react to it. Or vaccination, that's the other way. That's the purpose of vaccination. Has anyone here, so I was born in the 1970s, anybody in here ever have chickenpox? Right? Did anybody ever participate in a chickenpox party? Chickenpox party, right, is when all the neighbors would put their kids together, right, so everyone would all get infected at once, and therefore would all be taken care of at the beginning of the summer, and everything would be fine for the rest of the year. So that's a natural immunity, right? That is a natural way of learning that infection, developing immunity, and then having protection against it, okay? And as I mentioned, vaccination is the other way. Okay, so the immune system, as I said, is composed of many different cell types. The type that we're going to talk about mostly is the adaptive immune system. This is the part that learns, okay? The other part, this innate, is kind of the rapid thing, the pus that forms, stuff like that. This is the one that takes some time, and this is actually the basis for natural immunity or vaccination. Okay, so here's the way it works. This is a simple diagram, actually. Believe it or not, it is a simple diagram. So the way it works is that you have T cells and B cells. These are types of white blood cells. And when you get exposed to a virus or a vaccine or whatever, you have what's called a primary immune response. And what happens is the cells make more of themselves. They make clones of themselves, little what are called daughter cells, and they expand. And then you also make antibodies, and antibodies help soak up, essentially, any infection. And then that goes away, right? So you feel better, and it goes away. So then you develop something called immune memory, and that actually lasts months to years, okay? Can anybody take a guess? How long do you think, when you develop antibodies to measles, how long do you think those antibodies last for, or are supposed to last for? Take a guess. Keep going. Your whole life, yes. When you do the calculations, you have to extrapolate out. They will last for about 500 years, okay? So measles is supposed to stay with you essentially your entire life, right? The 500 years obviously is a mathematical calculation. We don't live to be 500 years, but it should be with you your whole life, essentially. So what happens then is these memory cells that are kind of floating around, circulating around the body, looking for when that infection shows up again. When it does, you get a secondary immune response. That is incredibly robust and incredibly quick. And since it's already seen the infection before, you mount this really nice response, and either you don't experience the infection at all, or you experience kind of a very milder version of it. And this is the basis of vaccination, and this is why we vaccinate people. And it has to do with T cells and B cells and antibodies. Okay, so we looked at our patients that we see in the NIH Clinical Center to see whether they had any indicators of immune problems. So we administered them a questionnaire that asked about things like sinus infections and ear infections and things like that. And basically, long story short, is that what I'm showing in this graph here, on this side and this side, is that yes, the patients do have a lot of symptoms that suggest immune dysfunction. What's interesting is one of the most common ones that we see is delayed recovery from infection, right? So something like, what is it, 80, 85% of our patients, when they get an infection, it takes them a long time to bounce back, right? And that means a lot of things. That means either a long time for the infection to go away or a long time for them to actually get back to their, how they feel better again or they feel healthy again. So that's probably the main complaint. But at least if clinically you ask them the right questions, right, and people don't always ask you these questions, what we find is that they have some indicators that their immune system is not functioning at 100%. Okay. We also looked, this is another study, and these are 62, that previous study was pediatric patients. This is also pediatric patients. So what's interesting is that a lot of patients have recurrent or severe infections, right? So this is putting them at risk, right? Putting them at risk for having complications, for having metabolic decompensation episodes, et cetera. So having these recurrent infections is something that we are, trying to address. Okay, so having a mitochondrial disease, okay? How well does the immune system function in mitochondrial disease? Well, we have some data so far that I just showed you, right, which suggests that the ability to fight off infection is not so great. So how about the cells themselves? How do they function? Do they work at all? Are they any good? So once again, we're going to be talking about the adaptive immune system, right, this kind of memory response. And what we see is if you look through the medical literature, you can find a whole bunch of people who have reported these things before, kind of here and there, in no large collection of patients, but kind of what are called case reports. And you find that there are individuals with low levels of antibodies. So hypogammaglobulinemia is a really long word. It just means low levels of antibodies. Antibodies are important for fighting off infection. Those are the titers that people measure. Those are antibodies, titers against vaccinations to make sure you're protected. So these are important for protecting you. Lymphopenia means white blood cells that are very low. So that's not good. You can have low CD8 cells. This is a type of white blood cell that kills virally infected cells. So those can be low. As low as low memory cells, which is the graph I showed you where you develop memory, which can last for years. And then when you see the infectious agent again, those are supposed to expand very quickly and very robustly. And patients can have very low memory cells. Okay, so that's what I'm talking about, this memory response here. They can't do this very well. Okay, so when we look at the immune cells in patients, so these are from patients, and on the left-hand side, what you will see is all the colored dots. These are all different types of mitochondrial diseases, and they're organized by what complex is affected, right? And there's also mitochondrial depletion in there too. And the hashed bars, which you see, is the normal range. These are memory T cells. T cells that kind of coordinate the immune response. They respond very quickly when you see, an infection again. And you can see that those numbers are very, very low, right? They're below the lowest bar. So they're out of the range of normal. So patients with mitochondrial disease, not all, but there are some that have very low memory T cells. The second thing on the left is, on the right, is these are a type of white blood cell called a B cell. These are the cells that make antibodies. You have memory B cells as well, right? Those are supposed to last for years. They make antibodies against vaccinations, et cetera. That's why we're protected for 500 years against measles, because of memory B cells. And you can see that certain patients, this is the normal here, that they are below, not everyone, but there are patients that have very low memory B cells. So therefore, they lose titers against things like measles and things like chicken pox and stuff like that. So that's concerning. Okay, so as I said, since we can't give infections to people, right, it's not ethical to do that, it's dangerous to do that, and I would never do that. We can do it to mice, and we can do it to mice that have mitochondrial disease. So this is a mouse that has mitochondrial disease in its T cells only, right? So that way you can say, how is having a problem with your mitochondria affecting your T cells only? The T cells, remember, they're memory cells. They kill virally infected cells. So we give these mice influenza. And then we look at the ability of those T cells to get rid of the influenza. And what you can see on the right is this is essentially a vaccination experiment. Sorry, on the left. This is a vaccination experiment where we vaccinate the mice with a strain of influenza, and then we challenge them later on with another strain of influenza. And if they function okay, and you look at the lungs, you should pick up no virus whatsoever. They should be able to clear it. And that's what we see for the animals that do not have mitochondrial disease. WT is wild type, no mitochondrial disease. They clear this infection just fine. The T cells that are affected by mitochondrial disease, their level of virus is about 100 times or more above what a normal mouse is. So delayed recovery from infection. It takes them a while. They don't clear it very well. This is what we're seeing in our patients, and we can see this in mice that have mitochondrial disease in their T cells. So we just published this paper recently, which is looking at vaccines. As I mentioned, T cells and B cells are important for making antibodies in the blood. The antibodies are made from the B cells with T cell help. So what we wanted to do, since unfortunately what's going on right now in this country with outbreaks and things, we wanted to make sure our patients were protected. So we looked at the levels of antibodies for all of the childhood vaccinations that they received. And what we found is that about 35% are missing antibodies. Everybody's been vaccinated, by the way. So that's, they at least tried. So 35% are missing Haemophilus influenza B, which is a bacteria which can cause sepsis, pneumonia, and horrible things. Hepatitis B is only 56% are negative. Measles, 20%. 1 in 5 patients with mitochondrial disease, right, are vulnerable to measles based on these data. Varicella, which is chickenpox, 65%, which is quite striking. And then individuals who have 2 or more missing titers, in other words, not having antibodies to 2 or more of these vaccinations, that's about 56%, okay? So we're in the process now, so what do you do, right, in that particular scenario? You revaccinate people, right? Because what we don't know is that did they not develop the antibodies in the first place, or did they, and they actually lose them over time? So that's what we have to try and figure out because we want to keep our patients protected and healthy. Okay, so looking at the vaccine response, T cells interact with B cells. They tell B cells what to do and make these antibodies to protect you. When you take a mouse that has T cell mitochondrial disease, they don't make antibodies very well. So all I'm really showing is this is the primary response, this is the secondary response. Let's look over to this one. Essentially, mice that have T cell mitochondrial disease don't make antibodies when we immunize them. Okay, we give them an immunization, we look time period 5 weeks down the road, they don't make antibodies. So if you have mitochondrial disease in your T cells, you have a problem with making antibodies. What about B cells? So the same thing is true for B cells. So B cells, if you look, the thing about B cells though is that the dysfunction does not show up right away. It actually shows up many months down the road. So this is a mouse that we actually engineered mitochondrial disease in B cells, right? So we looked at the other type of white cell which makes the antibodies. And when you look 7 months down the road, I just want to show this because it's a really nice picture. These are called flow cytometry plots, and they're just very colorful. The point of it is this. If you look in the lower right-hand corner, if you look in the lower right-hand corner, this one, here we go. There we go. This one is less colorful than that one. All that's telling you is as this mouse gets older, its B cells kind of drop out of the picture, right? So your ability to make antibodies and have those memory B cells that continue to make antibodies and protect you over time may actually, if you have mitochondrial disease, there may actually be a problem in B cells. Okay, so really, just to summarize very quickly, what happens is, in T cells, they become activated, they make a whole bunch of themselves to try and react to an infection, and when you have T cell mitochondrial deficiency, they essentially die off and don't form T cells, right? So they can't coordinate the immune response, they can't tell B cells what to do, bad situation. For B cells, if you knock out the mitochondrial function in B cells, it still happens, but it takes time. So this is something that happens over a longer period of time. So this may be explaining some of the things that we're seeing for missing titers in our patients, their susceptibility to infection, and their basically the recurrent infections that they may get. Okay, so last part, how do we protect people? How am I doing on time? Sorry, I have no clock in front of me. 5 minutes, great. Okay, so how do we maintain immune health? Well, as I mentioned, unfortunately, there's outbreak of measles going on now. This is the recent report from the CDC with regards to measles. There are over 1,000 cases so far of measles in this country. And it's no longer pockets. It's actually across the country. So these are things that we have to, so education and knowing where these things are occurring is one of the first ways that we can try and maintain immune health. So reduction of risk exposure, So if you know either through us or through your provider that your child's not protected against measles, then maybe going to Disneyland might not be a good idea because those are where large crowds of people gather and things like that. So being armed with information, knowing these things can be very powerful. Hand washing, don't discount the importance of hand washing, right? A lot of these things can be passed from sharing things, from touching things. You'd be surprised at how long certain organisms can survive on things like doorknobs and glasses and utensils. Okay, the vaccination schedule. So at this point, the current recommendation as it stands is that individuals with mitochondrial disease should adhere to the vaccination schedule. There are exceptions, of course, for individuals who are show severe immunologic dysfunction, but this is usually determined by an immunologist in terms of if there's any vaccine avoidance, that has to be made by an immunologist, that determination. Antibiotics, we do have individuals who are on antibiotics for prophylaxis to prevent infection, right? As well as Tamiflu. Does anyone keep Tamiflu in their house during the winter? Great, that's great. I'd like to see more hands, but that's great. Tamiflu is a drug, right, that helps prevent influenza. The reason I say in your house is because if it's not given within the first few days, it's not very effective. So what we generally recommend for our patients is to have it on hand, or at least have your pediatrician like on speed dial so you can get it pretty quickly, because when it is given early, it is actually quite effective in terms of kind of squashing the influenza infection. Okay, some patients actually require immunoglobulin therapy. Is there anybody in the room who is on immunoglobulin? Yeah. So there are individuals who actually have an immune deficiency that is significant enough for them to require replacement of those antibodies, right, that we talked about. And those antibodies protect you against all these different infectious illnesses. So there's an intravenous form. There's a subcutaneous form. And this is produced from humans. So it's anywhere between 10 to 100 humans, and the protection is pretty broad with this formulation. It's used to treat immunodeficiency, and we have had patients report other beneficial effects besides preventing infection, and we're looking into that in our protocol. Okay, so this is us. We're not too far from here. We're at 30 miles, I think, about 30 miles from here in Bethesda, Maryland. I just want to thank all the families who have come to see us, as well as you folks listening to me today. We're very privileged to be able to work with this community and work with you all, and we will still continue to do so. I also want to thank all the taxpayers in the room, because that's why we're here. This is a U.S. government institution, so thank you very much for paying your taxes. So we are interested in seeing more patients with mitochondrial disease, patients with Lee syndrome who have a very ominous relationship with infection where they can really have problems. We want to see patients with, children with all different types of mitochondrial diseases, because we want to know who has a problem with infection and who doesn't, right? Both scenarios can be very informative for us. And this is us. So that's me. We have Eliza Gordon-Lipkin, who is sitting over there, who is our staff neurologist. We have Shannon Crook, who is our coordinator, and this is our telephone, our information. We also have a table outside, so please stop by and see us when you can. Thank you.
Your hand, and then they really want you to be able to talk into the microphone so everyone can hear. Does anybody have a question?
And whatever questions don't get answered, please come up to me afterwards, and I'll be more than happy to answer them.
Hi, we were just
Yes, hi.
wondering if you're on SCIG, can you qualify for your study or no?
Yeah. So yes, absolutely. So we want to follow patients who are on immunoglobulin therapy already because we want to see, how do they do? Look, infection's inevitable, right, in all of us, especially in kids. There's a study that actually says the average child up to the age of 3 experiences 15 infections before the age of 3. Okay, so we want to see, in all children, whether they're on IVIG or subcutaneous or not, how they do with infection. Is it really working for them? And then also, what other benefits are we seeing besides the immune benefits?
Hi, my daughter was recently taken off her IgG because they thought it might actually be impairing her ability to ever be able to do that herself. So we just wanted to know your thoughts about that.
You mean the ability for her to form her own antibodies?
Yeah, so she was found to have a primary immune deficiency, but we
Right.
just found out she really has a mitochondrial disorder.
Right.
The doctor said to stop she took it daily in her
Yeah.
abdomen, to stop that and see after 3 months whether her body picks back up and actually had a primary immune deficiency disorder, or really was it just mitochondrial and doesn't really need it, but now maybe her body won't restart.
Right. So I can't predict that for you. Have they looked again? In other words, has it been
They redid the Pneumovax 14, and all the levels are within normal levels.
Okay, and her levels of antibodies in general, in other words, they call them immunoglobulins.
Right.
Are those normal in her blood?
Well, I know that sometimes, like when she's been vaccinated with something and then actually still would get the disease.
Right.
So it's always been a little iffy.
Right.
She's often been very, very sick.
Right.
So,
Right.
but-
Actually, I would be interested in talking with you a little bit more if you don't mind, just
Okay.
to learn a little bit more about, just so I can give you more of an informed answer, because there's a lot of complexity in there.
Thank you.
Yeah.
Yeah, how do you determine what is deficient enough to warrant immunoglobulin therapy?
Yeah, so that's a great question. So I'm not a clinical immunologist, just so you know. I'm a geneticist. We have an immunologist that works closely with our team. So there are clinical criteria that you have to fulfill, and it's basically called primary immunodeficiency. So it's demonstrated low levels of antibodies, but on top of that, the clinical picture also has to look like immune deficiency. So in other words, you have recurrent infections, or you have very serious infections that require, sometimes require intervention like draining or admitted to the intensive care unit, or require very heavy antibiotics. So it's not only it's a combination of what you find in the blood, but also what the clinical picture actually looks like. So there's a number of check boxes that they have to do before they will give it.
Anybody else in the back?
Is there an upper age to your study?
Yeah, so at this point we primarily do see kids. We do see adults, but usually the adults that come to us have either a diagnosis of primary immunodeficiency or something immune, already a diagnosis of immune dysfunction essentially. Because at this point we really primarily do see children.
And I've two more, 1 and 2, and then
And the reason, sorry, let me just say, the reason for that is not that we're biased against adults, it's just that we're all pediatricians on our team. So, there are obviously certain things that also come with being an adult and a type of medicine for adults, which is very different than pediatrics. That's the reason. Yeah. Actually, 28's not, so 28's, believe it or not, we still consider 28 even within like the adolescent range, so, yeah. I mean, if you can be on your parents' health insurance until 26, then, Sorry, go ahead.
So the basis for my question is, this is more, I guess, anecdotal.
Yes,
We were actually visiting this area a year ago,
yes.
and my son, who has mitochondrial disease,
Yeah.
was getting weary. His temperature went up a little bit, called the pediatrician at home, said, do the Tylenol, ibuprofen. And within a matter of a few hours, we were at one of the Smithsonian's, and his temperature went up to 104.
Yeah.
So we had to get him into an ambulance and get to Children's National
Yes,
Medical Center.
which is a fantastic institution.
Phenomenal. We
Yeah.
were grateful that we were here.
Yes.
And so they checked him out. They said it was just a brewing ear infection, and we got discharged, and antibiotics seemed to do the trick. And then we were also recalling we had been in New York City during similar time 7 years ago and had the same thing.
Yes.
And we were wondering if it was sort of the connection with all of a sudden for here it was about 20 degrees warmer
Yeah.
than where we live.
Yeah.
So is that something that we should be concerned about, like with the heat?
Well,
Could that
so-
bring on an infection?
Right, so there are some individuals who have dysautonomia, right? So an inability to control certain aspects of what's called the autonomic nervous system, and temperature control can be part of that. That is testing, though. That's, there's a lot of things to do for that testing. Dr. Gordon Lipkin can probably speak a little bit better about it than I can, but yeah, temperature instability can be a part of, your, it's called dysautonomia. So, and like things like blood pressure and stuff like that, they're all part of this kind of automatic system, which is constantly ongoing in your body, and individuals can have trouble with temperature stability.
Are there any possibilities of enrolling in the study if you don't carry an official mitochondrial disease diagnosis?
Yeah, so we like to have something, right? So in other words, because we do some studies ourselves to look at the mitochondria and how they function. So whether it's enzymology from a muscle biopsy or neuroimaging that is very like Lee's disease, right? A lot of Lee's disease diagnoses are made on neuroimaging because there's kind of a very a nice signature, for that. So we need something to go on, basically.
There's a question over here.
Yeah, I've had mitochondrial disease, and I'm on TPN.
Yes.
I have a central line. I guess I was wondering, as far as the numbers that are seen, as far as white blood cell count, and
Yeah.
thanks. I was sick 2 weeks ago with parainfluenza
Yes.
3. I've had a lot of dental issues that have not been taken care of, and a couple days into that, the cultures turned positive for Fusobacterium nucleatum in my mouth. So that's one area, and all my white counts were down, like 1.5, 1.3. My
Yeah.
ANC was like 600
Yep.
at one point.
Yep.
So that was this past time. I had an infection in October of 2016 in my central line. That infection I was really, really sick for. My ferritin level was over the limit of what their machine could test. It was
Yeah.
about 36,000.
Yeah.
And in that one as well, all my counts were decreased, and I was pretty sick. So I guess I'm wondering, does the dysfunction in an immune system swing sometimes
Yeah.
high and low like that?
Yeah,
or-
absolutely. So what you're supposed to do, or what your body's, not you, sorry, what your body is supposed to do and what your immune system is supposed to do when you get an infection is your white cell count's supposed to go up, right? And that was part of some of the figures I was showing. And the purpose of that, right, is to be able to fight off infection. So your story to us is not unusual. We have 3 other patients where we've been able to capture them when they've actually had an infection, and they do exactly what you're saying. Their white cell counts drop to essentially nothing, sometimes nearly undetectable by the machine. It turns out also, too, that their level of immunoglobulins drop as well. So that's not an unusual story, yeah. But unfortunately, what I didn't show you, actually, is when we make the mice that have mitochondrial disease in their immune cells, they do the exact same thing. So we think that is actually part of what's going on in individuals who do drop what are called their white cell counts very low.
Are there any tests that I could ask my doctor to perform in the future to? I don't even know if there's any treatment for it other than just getting the infection under control.
Yeah, I mean, so one of the things you might want to find out or discuss with your doctor is whether you have something called cyclic neutropenia. So in other words, this kind of waxing and waning of a certain population of white cells going up and down, which does occur in mitochondrial disease, because there are certain therapies that they can actually do for that. What did they? We can talk a little bit more offline, but because I'd be interested to hear a little bit more, because it depends on which white cells, et cetera.
So we probably have time for maybe one more short question. Does anybody have? I thought I saw one hand. So let's go ahead and thank Dr. McGuire for his time. And if you have other questions, He'll be at his booth out in the front, so that way we can clear this room for the next speaker. And then he'll be out in the hall or at his booth if you have other questions. Thank you so much, Dr. McGuire.
Thank you, everybody. I appreciate your time.
Our reception for Evening of Energy begins at 5:30, so we hope you all are joining us for our banquet tonight. Thank you.